Hello, everyone, and welcome to today's expert webinar for the 2019 MQII Learning Collaborative, focused on acute care to next site of care handoffs, continuation of the nutrition plan, documentation, intervention, and implementation. My name is Kelsey Jones, and I'm one of the leads for the Malnutrition Quality Improvement Initiative here at Avalier Health, and we are very excited to have Angela Lago speaking with us today. Before we get started, a few housekeeping items that I want to go over. All lines have been muted upon entering the session, so you cannot verbally ask questions. That will cut down on background noise. What we do ask is that if you have any questions, whether you're having technical issues or you have questions that you would like to pose to our speaker, please send them to us via the Q&A or chat function on WebEx. For some of you, you'll see that in the upper right-hand corner. It looks like a little chat box. For others, if you hover over the center of the bottom of your screen, you'll see a little button pop up that looks like a chat box or a chat bubble. Feel free to click on that. It will send us a message, and then we can either help you troubleshoot any technical issues you're having. We also will hold all questions for Angela until the end of the presentation, and then we'll pose them to her that way. So if you have any questions throughout the presentation, please feel free to send them to us as they come to you. We'll hold them until the end, and then we'll pose them to Angela in the order in which they're received. Now I'd like to introduce Angela Lago, our speaker for today. Angela is the Clinical Nutrition Manager at New Hanover Regional Medical Center in Wilmington, North Carolina, where she has worked since 2008. She is an active member of the Academy of Nutrition and Dietetics, is a member of the Clinical Nutrition Management Dietetics Practice Group, serving on the Professional Development Committee this past membership year. Angela obtained her BS in Nutrition from East Carolina University in 1999 and completed her dietetic internship at Winthrop University in 2001. She earned her MS in Nutrition from East Carolina University in 2006 and has been a certified nutrition support clinician since 2009. Angela has been part of the MQII Learning Collaborative since 2017 and has focused on malnutrition throughout the continuum of care for the hospitalized patient, most recently shifting her focus to the transitions of care for the malnourished patient upon discharge. Angela and her team were awarded a Duke Endowment Grant to help further their work in the malnourished patient population, and she was recently awarded the People's Choice Award at the 2019 Clinical Nutrition Manager Symposium for her poster titled Bridging the Gap from Hospital to Home, Implementation of a Malnutrition Transitions of Care Program. We are very excited to have Angela with us today. She has been a fabulous MQII participant since 2017, and I will now turn it over to Angela to share some insights about the work that she has been doing at New Hanover and how she got to where she is today. Thank you, Angela. Angela, you might be muted. You may need to unmute yourself on the computer.
Can you hear me?
Yes, great.
Hello? Okay. Sorry about that. Good afternoon, everybody, and thank you, Kelsey, for that introduction. I look forward to speaking with all of you today about the work that we've been doing at New Hanover. And as you see on the first slide, the objective that we'll be talking about today is I just want to tell you guys about the journey that we've taken here at New Hanover, how you too can implement a transitions of care program at your facility, some of the impacts and outcomes that we've seen here, and what the future looks like for us. New Hanover is located on the southeastern coast of North Carolina. We are the largest employer in the county, employing approximately 7,000 individuals, and we are licensed for 800 beds. We have a Level 2 trauma center, bariatric center of excellence, women's and children's hospital, behavioral health hospital, Level 3 NICU, inpatient acute care rehab hospital, and an orthopedic hospital. We additionally have several outpatient clinics that my dietitian staff also services. I have 16 dietitians, including myself, on staff, 11 of which are in the inpatient adult nutrition world and very much involved with this project. As Kelsey stated, today's presentation will focus on the work that we've been doing in the transitions of care space. However, I would like to start by telling you a little bit about the work that we have done that led us to the point we are now. Approximately 3 years ago, we kicked off our efforts to streamline our identification and documentation of malnutrition using the Aspen and Academy malnutrition consensus criteria. This included many aspects such as forming a robust interdisciplinary team, streamlining our screening tool, and we use the malnutrition screening tool, training the registered dietitians on performing the nutrition-focused physical exam, working with IT to optimize our electronic medical record, and we have Epic here at New Hanover, and a lot of education for the coding team, the clinical documentation specialists, nurses, and providers. While preparing this presentation, it's been really interesting to look back and see each small detail that went into getting started with this program and where we've come to today, such as getting a standardized definition of malnutrition approved by our P&T committee, determining what data would be meaningful to track, discovering our baseline capture rate, and I'll tell you a little bit more about that later, and even just the small things of trying to decide which disciplines we needed at the table. We were able to demonstrate that there was a significant increase in the number of patients identified and treated with the diagnosis of malnutrition through having that hospital approval of the standard definition of malnutrition, the focused education of all clinical staff, and a consistent approach to nutrition screening. In addition, increased reimbursement was captured, along with a decrease in the mortality index. For those of you that are not familiar with mortality index, malnutrition helps lower the score because you're giving more evidence as to how sick the patient truly is. Therefore, the expected death rate over the actual death rate is a more narrow of a margin. So you wouldn't want at your facility to have more people that are passing away than you would expect based on how sick they are. Hold on one second here. We submitted our work to a quality focus conference in our state and won a Silver Touchstone Quality Award, which was very helpful as we started thinking about our next steps. At that time, we were thinking about expanding into the pediatric population, as well as exploring post-discharge opportunities to provide continued care outside the walls of the hospital. We also wanted a way to show the impact of our nutrition interventions on reducing readmissions. Even with those goals in mind, we felt like we were at somewhat of a plateau, and we just weren't sure what our next steps should be. It was around that time that I learned about the MQII, and with the awareness that we had raised in the hospital combined with the quality award, we were nicely positioned to have the support of our administrative team when we asked to join the MQII. I truly feel really fortunate with the support that I've had here, and this is something that I get asked about a lot when others reach out to me. There's many people interested in implementing the same type of program, but they just have not had the same support. So, and I do realize that it's not so easy to gain that supportive leadership team, as this project requires a lot of resources from multiple departments. And as Kelsey said, I've been working on it with the MQII for 2 years, and it truly has taken a lot of time, but it's been very, very valuable time. So my advice to those of you who have had this problem is, one, to make sure that you're familiar with the electronic clinical quality measures. And once you are, reach out to the quality leader at your organization to discuss them. Also, make sure you're talking to the right person at the right time. If your VP is someone that's not a clinical person, perhaps that's not the right person to connect with initially. You should also make sure you have the right people on your interdisciplinary team. I really wanted people that were passionate and that could see my vision, or maybe they had their own vision related to malnutrition. and could provide some extra insight. I also think that you need to think about how you have positioned yourself within your organization. Does your leadership understand the value of your team? Do they value nutrition intervention and understand that? If not, that's definitely where you should start. Finally, this work was directly aligned with the goals of New Hanover. I think each of you should become familiar with what's important to your organization and see how this can fit into your own organization or hospital goals. In the spring of 2017, we joined the MQII, and that was an integral part of continuing to move this initiative forward. Our interdisciplinary team changed a bit as we pulled in a nurse educator, clinical informatics, a data analyst, and clinical outcomes. We started by mapping our workflow and selecting our QI focus areas, which were the nursing screen, provider, education and communication, and post-discharge nutrition plan of care. And you can see those three worded slightly different at the top of the slide. As we dove into the first two QI focus areas, we found many broken processes, as you can imagine, which in turn led to quite a bit more education and awareness around malnutrition and the desired workflow. Much of the education has been one-on-one between providers and dietitians or between nurses and dietitians. However, I have made it a point to regularly attend Nursing Congress and Nursing Practice Council meetings to keep them up to date on our initiatives, our progress, and how they can help us. I also meet routinely with nursing leadership to make sure I have their support and help them understand my initiatives better. And as you can see here on the slide, the nutrition screen is the link to every other process that we have in place. For the most part, if the nurses are not getting that screen completed, we miss a good amount of patients that we really need to be seeing. Throughout the Learning Collaborative, we were able to gain great insight into exactly what was going on at New Hanover from the performance data on the ECQM report. In the performance measures table above, you can see that my staff was only getting the patient screened as at risk for malnutrition within, with best practice guidelines of 24 hours 30% of the time. And 76% of the time, we're getting to them within our policy time frame of 48 hours. More shockingly, 30% of the patients never received a nutrition assessment prior to discharge, even though they screened at risk. We were able to correlate this not only with the nursing screen not consistently getting done within 24 hours of admission, but this was also compelling data to use when justifying the need for more RD staffing. And I would like to mention during this time that our average length of stay was 4.5 days. So if it was taking 2 or 3 days for the nurses to get that admission screen done, it's quite possible that's why there were a good amount of patients that we could not get to. We did add 2.7 RD FTEs to our staff earlier this year, and we have since improved to seeing 42% within 24 hours and meeting our policy of 48 hours within 83% of the time. But as most of you probably also experience, our organization has continued to grow, so we still have difficulties feeling like we have enough staff. Information such as this has helped guide us with which interventions we need to focus on and also track our progress or lack thereof. So many lessons were learned that year, yet we knew our most difficult task to tackle was on the horizon, which was to start looking closely into the post-discharge nutrition care of our malnourished patients. We really knew that no matter what we did, while the patients were in our care, many were simply not going to continue on the road to healing without additional support once they return home, and possibly return to our facility in worse shape than they left. I know this is a very busy slide, but I felt like it was really important to share. In April of 2018, we held an all-day malnutrition transitions of care lean event. The flow chart on this page was created from the information gathered that day. This event had various stakeholders present that I had never worked with before because many were in the ambulatory setting. I started by giving a presentation on the, I guess you could say, state of malnutrition at New Hanover. And then we mapped out the current workflow again, this time extending into the post-discharge care of our patients. Each of the squares on this slide represents individual steps of the patient's journey from the time they're admitted to the hospital through post-discharge. And then the red Kaizen bursts that you see are barriers that were either perceived barriers or actual barriers along the way. So then we discussed these barriers as a group and tried to figure out what was keeping us from effectively communicating malnutrition interventions and education across the continuum of care. And as you can see, there were many. We then separated into two groups and discussed what we felt was needed to be successful in bridging the gap between the hospital and the patient's home. We left that meeting with next steps organized into easy, medium, and difficult, with a plan to begin the easy tactics immediately. And honestly, I wish I could say that we had checked off all of the recommendations that were made that day, but that's definitely not the case. It's much harder to work across the line from inpatient care to ambulatory than you would think. One of the main takeaways from that event was the connection that I made with the community paramedic that attended. I'm not sure how many of you are familiar with community paramedic programs, but the one that we have had here has been very successful, and they make home visits to patients that are considered high risk for readmission patients. They too started out as a grant-funded position with one community paramedic, and now, several years later, they have 5 full-time community paramedics. This model really resonated with me, and this is where I began thinking about having a registered dietitian making home visits to patients identified as malnourished during their hospital stay. Additionally, during this event, the administrator of community relations was present. He had been charged with helping our organization come up with a plan to address health equity and social determinants of health in our community. And I feel pretty confident that a good number of you also have that focus in your organization now. He saw the opportunity to pull my initiative under the food strategy umbrella, and I'm so thankful that he did. In spring of 2018, we applied for a Duke Endowment grant to address food insecurity in the community, the acute care setting, and for my project specifically focused on the malnourished patient population. That June, we were awarded the grant, which is currently funding a full-time clinical outreach dietitian, salary and benefits, mileage, technology such as a laptop and cell phone, and then any marketing around that role. I should mention that the grant is also funding other initiatives under the food strategy umbrella, such as a food pharmacy and efforts to open a grocery store in a known food desert in our community. As I stated, as part of the grant obligation, we needed to add a component to address food insecurity, and this was not something I had previously been thinking about very much. I worked with our social worker coordinator to organize a pilot to assess exactly how much of our patient population may be food insecure. We needed an estimate to take to our VP to gain approval to donate these boxes in kind out of the Food and Nutrition Department. At that time, we really had no idea what the ask was going to be. We used a tool called the Hunger Vital Signs, which is a validated screening tool some of you may be familiar with, and we found that out of our sample population, 20% were food insecure, and then 20% of those that were food insecure were also malnourished. My director took on the task of designing a food box that would be given to these patients at discharge. And I'll add, too, that we had no problem getting approval to give those in kind to our department. The food box that was designed provides 2,000 calories a day for almost 2 weeks, and that's if it's consumed by only one person. We know that oftentimes there's more than one person living in a home, perhaps if you have an elderly person that's raising grandchildren or a caretaker that's living in the home with the patient. So we realize that some of the food boxes are not going to last the full 2 weeks, and we're good with that. And you can see a picture on the slide of some of the items that are in the food box. And we often get asked about the lack of fresh produce and the presence of so many convenience items. I think it's really important to remember that these folks are food insecure, meaning they often or sometimes run out of food and don't have money to buy more. Unfortunately, sometimes patients are faced with choosing between buying food or buying their medicines, in which case they buy their medicines. We've also had situations where patients don't have refrigeration, so we have to remove the perishable items from the box. Our main goal was to have a food that required minimal preparation and to also provide enough food to bridge the gap until the dietitian is able to make the home visit and set the patient up with appropriate resources in the community. Along with the food box, we do hand out a few educational sheets, and one you can see part of it here on this slide that lists all of the items in the box, and then we have meal ideas that you can make using the ingredients that are in the food kit. And you can't see that here, but at the bottom we have information about perishable items that are included in the box, and we write the date and the time that the perishable items need to be refrigerated. And to date, we've given out 45 boxes to malnourished, food insecure patients. This is the second insert that we put in the box, and this is for information on a web-based tool called Our Community Link. Some of you may be familiar with that in your area, and if you're not, I encourage each of you to just type in that web address and see if you have this service in your area. We will soon be converting over to a more robust system that has a trackable referral system so we can see when our referrals were actually received and when the patient followed through with that referral. And that's called NC Care 360, which is also available for any of you to look up if you're interested. And basically what they are is large databases of resources throughout local communities that address all social determinants of health. They describe what the services are that are offered, what areas they serve, what the qualifications you need to meet are, and all of that type of information. As you can see in the example here of Our Community Link, they have the different topics across the top, and you just select if you're interested in food, housing, transportation, and then you can choose, for example, in this picture I chose food pantries, and 13 food pantries came up. And then you can see which one you meet the criteria for or which one's closest to your home or to your patient's home. So now I'd like to move more into the specifics around the clinical outreach dietitian role. As I mentioned earlier, the community paramedic model appealed to me when thinking about meeting the needs of our malnourished patients. We decided to go this route because we wanted to remove any barriers that could possibly be in the way of providing individualized care to these patients. By going to their home, we eliminated the possibility that transportation would be an issue or that they would have to choose between a doctor's appointment or a nutrition visit, in which they would most likely choose the doctor's appointment. I had so many ideas in my head of what I wanted this to be like, so I really decided to put it into a value stream map, and unfortunately this is the way that I think, and so it made me feel very happy to get this on paper and out of my head, but it helped other people be able to see my vision. It helped the dietitians that work for me see how they're connected to the process, and then it also helped the EPIC team understand the workflow that I was looking for. And then finally, when my clinical outreach dietitian started, it was very clear for him to understand what his work was going to look like. So in this particular slide, the green boxes are all things that we were currently doing at the time. The purple boxes were things that were approved but not built yet in EPIC. And then we're focusing for this piece of the presentation on the red boxes, which are all of the things that are part of the new process. And then once again, you have the red burst that identify potential barriers. So the new process, like I said, starts where the red boxes are. And once the patient is diagnosed with malnutrition by the dietitian, the new process is that the dietitians ask the patient those hunger vital signs. If they are food insecure, the dietitian would refer the patient to the clinical outreach dietitian as well as write an order for a food kit. At the time, we were also making referrals on patients that were diagnosed with malnutrition and had a high-risk readmission diagnosis. So those patients did not get the food kit, but they did get the referral to the outreach dietitian. We did make some modifications to this once we got started. You can see this is a very busy process, but just for example, we wanted to keep the patient referral list manageable. So initially we were only making the referrals, like I said, to those two groups, and the scope was a little too narrow. So we modified it to all malnourished patients being discharged to a home setting would get a clinical outreach referral. Additionally, we have not yet reached the point of having our discharge case managers referring patients to this dietitian. So far, we've been unable to handle that workload with only one RD. We also needed to decide how the clinical outreach dietitian was going to prioritize the workload. How often calls should be made, how often the patient should be visited, and when we would sign off. What you can see in this slide is our original plan to prioritize based on the malnutrition risk level. However, once this dietitian started, we landed on each patient getting a call within a couple of days of discharge. At that point, an initial appointment was made, and we really try to have that within the first week that the patient's home. And then we have a 30-day visit as well as a 90-day visit, and then at that point we sign off. And we're really hopeful that by the time we sign off, all of the connections in the community have been made to get the patient's needs met. To make this a little clearer, since not everyone thinks in flowcharts like myself, we did create standard work that outlines the entire process. Here you can see the first 5 of 12 steps. I was recently asked for the standard work when we had a survey going on here at New Hanover, as the group that was here was looking to see the different ways that we're working to keep patients from being readmitted. So I think as you start talking about this more and more at your organization, you will find that many others see value in this work, maybe sometimes from a different perspective than you would, but it's still very valuable. I'd like to go back to the food box process a little further, and you can see part of that outlined at the bottom here. If any of you are considering implementing something like this in your organization, I think it would be helpful to realize ahead of time that there may be some challenges with determining the timing of discharge, as in the actual time the patient leaves the building. How this will be communicated from the nursing unit to your department, how that affects your delivery time, who will deliver the box to the room, will you include perishable items in the box, or will you just leave it all shelf stable? Just as an example of something we experienced, if the RD identifies a patient as malnourished and food insecure and orders the food box on day 2 of hospital stay, the patient may not actually be discharged until day 8 of their hospital stay. This has been a challenge, and our current process includes ordering the food box, ordering the social work consult that specifies that the patient needs a food box delivered prior to discharge, which prompts the social worker to call the dietitian when they have a discharge date and time, and then the dietitian delivers the food box to the patient's room. Currently, the food and nutrition department keeps a par of 2 food boxes refrigerated at all times. Here you can see the order that was created for the inpatient dietitians to refer patients to the clinical outreach dietitian. And then if they need to order a food box, they do that during the same order set. We worked closely with the IT department to get this order built, and it helped that they were already able to kind of understand what we were looking to achieve, because we were able to use the community paramedics order sets and their work queue as an example. So once the order is placed by the dietitian, it flows over to the work queue. The clinical outreach dietitian reviews this list each day and makes calls to patients that have been discharged home. At that time, as I said previously, an initial appointment is scheduled, and patients that are discharged to a skilled nursing facility, treatment centers, or other facilities are not seen at this time. Okay. So here at the bottom right corner, you can see Skip Allen, and he is our clinical outreach dietitian there in the white polo shirt. He has been absolutely amazing and perfect for this role. He's so comfortable with the patients and their families going in their homes, and that's really the type of person that is ideal for this role. On the left and middle, you can see the initial and follow-up flow sheets for the home visits. In Epic, when you're actually charting on a patient, there are drop-down boxes under each section that can be selected. For the presentation today, I used a flow sheet that had already been filled in. But in addition to this, a full assessment is completed for each visit, along with a nutrition-focused physical exam. We wanted these specific navigator flow sheets so we could pull the discrete data out for collecting data on the reports. So we have a transitions of care report that Enterprise Analytics built for us with the help of Angel from Avalier to pull outcomes on these specific data points. For the initial appointment, about an hour is spent with the patient in their home. He has full access to the inpatient dietitian nutrition notes, and during the first visit, the interventions and discharge plans that the inpatient dietitian reviewed with the patient are reviewed again. Skip is able to review the patient's progress in meeting these goals and identify any barriers that they have with following through. He's really able to get to know the patients, to see what their situation is, if they're living alone, if they have support, if they have transportation, if they're able to access food and prepare it as well, or if they have financial constraints that are preventing them from nourishing themselves. Some of the common interventions that are provided are referrals to SNAP or food stamps, Meals on Wheels, food pantries. He also passes out oral nutrition supplement coupons and samples and provides a lot of nutrition education. Here you can see some of the patient comments that we frequently get, and these are very meaningful to me. Just hearing these comments makes all of this work so worthwhile, and it's also very meaningful to be able to share these with your executive team, because it really shows how you're making a difference in the community. And as I mentioned earlier, it falls directly in line with the mission of my organization. One of the main outcome measures that we're looking at is the 30-day readmission rate of malnourished patients, and we're comparing that to the all-cause readmission rate. As you can see from the graph, readmission rates for malnourished patients started falling toward the end of 2018. From January to May 2019, we saw a drop in 30-day malnutrition readmission rates of 18%, going from 20.35% to 16.67%. Starting in December, before SKIP started, we began collecting names of patients that qualified for a home visit, as well as distributing food boxes to malnourished, food insecure patients. After orientation and training, this list was used to start scheduling home visits. This is an outcome that I encourage each of you to use as you move forward in your transitions of care work. To get this data each month, I worked with business intelligence in our enterprise analytics department, and I'm sure each of you have something that's exactly the same, maybe a different name, but there's probably someone in your organization that's responsible for this data. So now each month, I'm able to go into this database and pull out these numbers. Moving forward, I would like to look at specific numbers associated with the percent decrease and put a dollar amount on the reduced readmissions. In addition to the readmission rate outcomes, we're also looking at reduced hospital utilization of patients that receive the clinical outreach home visit. We're looking at a percent decrease in utilization. So when you look at this bar graph, you'll see that the bar is higher on the intervention group than the control group, which shows that the group that received the home visit had a larger decrease in utilization than the group that did not receive the home visit. The control group consists of those patients that the clinical outreach dietitian was unable to contact or that refused his service. To break this down a little, for the emergency department encounters, the intervention group had 16% less ED visits and 32% lower associated ED charges. For the inpatient encounters, which would be an hospital admission, the intervention group had 17% fewer admissions and 24% lower hospital-associated charges. Additional outcomes that we will be reporting on in the future are changes in BMI and their nutrition-focused physical exam at 90 days post-discharge. One of the unintended outcomes that we have had is the amount of interest others have had in our work. I truly had no idea how many conversations this would spark with individuals that I've never met. Here you can see some of the ways we have been disseminating awareness about our program. As Kelsey mentioned, earlier this year, this program was selected for the People's Choice Award at the annual Clinical Nutrition Manager Symposium in Atlanta. I was so honored to know that so many of my peers found value in this work. Additionally, at this year's Aspen Conference, Angel from Avalier, Jennifer Wills Gallagher from UNC Chapel Hill, and I were able to present a roundtable discussion on this topic. We have various other initiatives going on at New Hanover that are running somewhat parallel to this program. These are two of my dietitians at our Zimmer Cancer Center, and they are currently in a pilot where they're giving food boxes to any food insecure patient that is receiving cancer treatments in our facility. These boxes are donated from a wonderful organization in our community called Nourish NC. And to date, through the Cancer Center, we have given out 60 boxes to our cancer patients. Additionally, we have a pediatric specialty clinic that is doing the same thing, and they're focused more on children and families. They have distributed 130 boxes to date. These initiatives are all part of the food strategy team that is currently working on the development of a food pharmacy, which will serve all food insecure patients that are admitted to New Hanover. This will likely be sometime this fall, and at that time it's possible that we may stop donating the food boxes from food and nutrition, and we may utilize the food pharmacy instead. Okay, so what does the future look like for us? We plan to continue collecting and analyzing data in order to solidify a permanent clinical outreach dietitian position. As you remember, it's a grant-funded position right now. We're very hopeful that, like the community paramedic program, we will be able to expand the team and be able to reach more of our patient population. We've kept it very narrow so far just to be able to provide outcomes and improve our effectiveness. I believe with a program that touches so many parts of the organization, we will also have to continuously be driving home the key pieces of this process. I'm hoping to have an annual computer-based learning module created for all nursing staff, because without an accurate nursing nutrition screen on admission, many patients will miss the opportunity to benefit from this program. As some of you may know, Malnutrition Awareness Week is in September. This year, my staff and I are going to be organizing a large campaign for that week, and we are thinking about introducing a mascot or symbol that we can put in or around a patient's room that would identify that that patient has been diagnosed with malnutrition. This would serve to increase staff awareness of those patients. So, for example, if a patient has an oral nutrition supplement or a meal tray sitting at their bedside, it will prompt nursing staff to encourage the patient to consume it. Or perhaps if a patient is on a tube feeding, it will not be held longer than necessary. Marketing is also on board with this, and we plan to have some public-facing information going out as well into the community about malnutrition. And then finally, we have had some initial meetings about closing the loop with the physician practice groups in our ACO, or our Accountable Care Organization. There are 5 transitions of care case managers within the ACO that we plan to connect with to see how we may be able to work together in the future as we expand. And I'm also hopeful that working with them will help us justify the need to have more clinical outreach dietitians. So I thank you guys so much for participating today, and I hope that you found some of the information that I shared valuable, and I'll try to answer your questions as best as possible.
Great. Thank you so much, Angela, for that insightful presentation. As a reminder, if you have any questions for Angela, please send them to us via the chat function or the Q&A function. You can access that by kind of scrolling over the bottom center of your screen where you'll see the slides being presented. You'll see a chat bubble pop up. Click on that, and that will allow you to type in a question and send it to us, and we can ask Angela any questions that you have. So Angela, the first question that we've received is, how would you suggest doing this if my site does not have the support to hire a social worker or a home health dietitian that can play the role that you have with SCIP?
Can you repeat that?
Are there any other models that you've? Yeah. If my organization doesn't have the resources or support to hire a home health dietitian like SCIP, do you have other suggestions for how we might do a similar program? So I guess the question is, have you seen other models implemented or other ways that individuals have sought to kind of do that follow-up post-discharge without having somebody that can actually go into the home?
So I haven't really seen any other models, but in thinking about it real quick here, I think if you can create some relationships with community partners or people in your community like Meals on Wheels, the food banks, food pantries, maybe different churches, and gather a list of resources available in the community, so when you come across a patient that you identify in your facility that's going to need help when they leave, maybe you can have a way of communicating with the providers on the outside, or you could at the very least provide your patient with a list of those services that are available to them in the community, because we have found that most people have no idea how much is available to them.
Great, and I know that's been a challenge for many of our sites, is even just trying to figure out where those community resources exist and how to get connected to them. So that's helpful guidance. I also thought the My Community Link resource was a helpful recommendation. Mm-hmm. You mentioned that many of these patients are food insecure or food insecure and malnourished. Are Are there any other commonalities that you see in the majority of patients that are receiving these boxes? Do they tend to have a specific diagnosis or other comorbidities that you're noticing?
It's hard for me to say right off, but the patients that are food insecure and malnourished also have, it's like they don't have just that one social determinants of health. And I'm not sure how familiar the audience is with that phrase, social determinants of health, but a lot of times if they don't have food, they also have a hard time with transportation. They may not have a primary care provider. There's a whole slew of issues that come around that population. So I'm not sure if that really answers the question. And if that person would like to leave their email with you, I can look through our data and see if there's common diagnoses among that group.
Okay, great. Thanks. I will pass that along. Another question is, what has been the biggest challenge in trying to implement this? Is it, that it took away time and resources that you had for other projects, getting the appropriate staff involved? What are some of those barriers, and what did you do to overcome those challenges?
So I think when I'm thinking of it, if we ask Skip, he may have some different answers, but when I'm thinking of it, it was just helping other people see my vision, determining exactly what I wanted to happen, and then translating that to others. So if any of the callers or participants have Epic, it's not easy to get things built in Epic. So just going through that whole process of getting the workflow built, trying to determine what was going to be valuable, and then honestly, without the grant, hiring the dietitian probably would have been the biggest barrier because it's really difficult to get staffing. So I'm super thankful for the grant, and I encourage everyone to try to get a grant if that would help them go this route, because it really gives you time to be able to prove the value without having the stress of, supporting the dietitian at the same time.
Right. And related to that, if someone was looking to pursue a similar grant, how did you identify the grant that you all did pursue? And do you have any tips or recommendations on how to make that a successful grant proposal?
Well, luckily for me, this grant was brought to me by the administrator in our facility that has ownership of the food strategy umbrella, as I pretty much described it. So at the time, he was looking for people that were interested in the same type of work. So I'm really grateful that I invited him to my meeting that I had for the Lean Kaizen event. So I can't really take a whole lot of credit for writing the grant, although I did help give information for that, but I don't have a lot of information on grant writing at this point.
Okay, great. Another question is, my organization is a rural community hospital, and we have more limited resources. Do you have any recommendation on how we could support discharge planning and follow-up without having quite the same scope of resources that you all do?
Mm-hmm. Well, that is a difficult one. I did work for 7 years in a small rural hospital, so I definitely understand that that burden. I think it would probably be similar to what I said before, is seeing what is available in the community, and then perhaps, I don't know, that's a hard one. Just seeing what's out there, or maybe seeing if there's like a larger city closer by, if they have any rural health initiatives that could reach out into your community, because we do that here. We're a very, very large organization, but we extend ourselves out into more rural areas to help them. So that would probably be a good place to start. I'll have to think on that one a little bit.
Okay, great.
I'm sorry I can't answer the questions a little better.
Yeah, no, not a problem. Can you go into more detail about how you are tracking your readmissions and tying them to malnutrition? I think this is a challenge that many of our sites have, is showing that these programs are actually impacting patient outcomes.
Right.
So do you have any suggestions on how to actually capture that data and track it and, try to explicitly tie it to your patient population?
Yes. So I worked with the business intelligence department within Enterprise Analytics, which is like the people that handle all of our data. And I specifically outlined the patient population that we're focused on. So she created a report that has, 18 and older, acute, inpatient, and then the 4 diagnoses for malnutrition, the DPG codes, and she created a report basically that I can pull specifically what I'm looking for. And then I can look at the readmission rates of that specific population. And then I can remove I said DPG, I meant DRG. Then I can remove those DRG codes and look at the same, everything else the same, but it's the all-cause readmission, so it's not exclusive to malnutrition. So if you're in a smaller facility and you don't have the capacity to have a report built like that, I could see that it would be more difficult. But here, thankfully, I have the report that I can just pull up. Now, the utilization report is a little more complex, and we had someone else build that report. And I could explain that to someone one-on-one, probably easier if they're interested in learning about that. But, yeah, I try to keep it as specific as I can to the population that we feel like we are affecting. And with the control group and the intervention group in that utilization study, all of those patients had malnutrition care on the inpatient side. Only the control group did not have the home visit. So we're trying in that piece to look at the effectiveness of just the home visit, if that makes sense.
It does, and that's really helpful to understand kind of how you're differentiating between that control and that intervention group. One last question that we received for you: how are you collecting the kind of informal feedback that Skip is receiving regarding the benefits of the program? You kind of shared some quotes. So how are you collecting that, and have you shared that with your leadership? Have they had any response to that?
So one of the quotes, I was actually with him on a field ride, so it was said to me. And then the other 2 quotes that I had on that page, he reported to me. Because since it's a grant position, I'm constantly asking what kind of feedback are you getting? Have the patients, have you heard any direct comments, direct feedback? And so he gets a lot of feedback because he forms a relationship with these people because he's in their homes quite a bit. We did report out at a lean event a couple of weeks ago and had those same quotes on the board, and a significant part of leadership was there. And I definitely plan to bring that up as often as possible because I feel like that's really where it's at. When a patient says, I feel like the whole hospital is behind me, and we have a mission statement of leading our community to outstanding health, it really has an impact.
Yep, and I think that really brings it full circle between, all the hard work you did up front to try to help the leadership understand why malnutrition was important and the potential impact that it could have not only on patient outcomes, but kind of on overall cost to the health system, and then to kind of bring that back around and to have both the quotes as well as the readmission rate reduction that you've seen, I'm sure is very impactful for your leadership, and obviously, has brought a lot of great recognition to your team as well. So congratulations for that.
Yeah.
All right. If there's not any more questions, we'll go ahead and wrap up for the day. If you all have further questions, please send them to malnutritionquality@avalier.com, and we'll be happy to pass them along to Angela for her to address via follow-up communication. Please note that following today's webinar, you will be receiving an email within the next day or two that will contain information on accessing your CPEU certificate, as well as the recording of today's webinar and the slides from today's webinar. As always, those resources will also be posted on the MQII Learning Collaborative member portal, which you can access at malnutritionquality.org. So please be on the lookout for that follow-up email, and you're also more than welcome to go onto the website and pull off the resources from that location as well. Please don't hesitate to reach out if you have any questions, and thank you all again for joining us today. Thank you, Angela.
Thank you.